Thank you for taking the time to join us today. My name is Ryan Holywell, and I'm the Communications Manager for the Texas Medical Center Health Policy Institute in Houston. The Texas Medical Center contains 59 institutions, including hospitals, medical schools, and research organizations. With more than 10 million patient encounters annually, the Texas Medical Center is considered the largest medical complex in the world. Today's survey was led by the Texas Medical Center Health Policy Institute, the TMC's effort to drive innovative, evidence-based health policy initiatives across our institutions. We'll be tweeting today using the hashtag TMC Health Policy, and we invite you to contribute as well. You'll hear today from Dr. Arthur Garson Jr., Director of the TMC Health Policy Institute. Dr. Garson is a cardiologist as well as an expert on public health. He previously served as Provost of the University of Virginia, Dean of its medical school, and President of the American College of Cardiology. You'll also hear today from Dr. Stephen Linder, our Associate Director. In addition to his role here, Dr. Linder serves as Director of the Institute for Health Policy at the University of Texas Health Science Center's School of Public Health. We'll discuss the results of our survey for about 25 minutes, and then we'll do 20 minutes of Q&A. You can call in to the phone number at the end of the presentation for your questions. You can also look at the top left corner of your screen for the Q&A button. I'll now turn it over to Dr. Garson.
Thank you, Ryan, and welcome to every one of you. This is the third year that we've done a survey of the public. First year we had 1,000 Texans. The second year we had 1,000 from each of 5 states, and this year 9,200 from 5 red states, 5 blue states, and 5 swing states. The survey was completed in August, just a few months ago, and we used an online protocol with a national firm, the Pearson Consulting Group. As is usual, the asterisk is p less than 0.05 for statistical significance. Interestingly, to all of us that don't deal with huge numbers, 9,200 small differences do count. This year we also did a physician survey. Only physicians currently spending at least 50% of their time in patient care. Again, online, survey completed at the same time. We had 452 physicians, 241 in primary care, and 211 specialists. So now to the results. Turns out having health insurance is really important. 98 to 99% of the respondents in all states, red states, blue states, swing states, all together, if you really flip it and say, to whom is it not important? Only 2% maximum say it's not important. Now I'm going to ask Stephen Linder to comment on some of these things as we move forward. Stephen, what do you think about this? What does this tell us?
Well, we'd expect the way people vote to be consistent with their views on coverage. And we find, comparing the red states, blue states, and swing states, that it appears not to be a partisan issue, that coverage holds regardless of party vote, of party alignment in the states, and falls out of the normal partisan contention.
The interesting thing about the swing states is they're right in between in this and virtually all the other data. When you look at our slides on the web, we will have all of them in, but for this presentation, we will show you red states and blue states. So what we then did was we said to people, okay, what's most important to you? Rank what's most important to you in a characteristic of the health system. And interestingly, certainly, again, red and blue, about the same, the greatest number said healthcare coverage for everybody was the most important. This has sort of blown me away a little bit in that you'd think that treatment causing patients to get better would be important, but pretty much 2 to 1, it's basic coverage for everybody. Stephen, what's your thoughts here?
Once again, we'd expect the trade-off between coverage and choice to reflect the party alignment in the state overall. And choice was a red state issue, and coverage was a blue state issue. But as we saw on the last slide, there's a nonpartisan response here, and they prioritize coverage regardless of the voting alignments within the states.
Now, we then said, okay, since it's so important for everybody, and pretty much everybody has said, we need health care coverage, what's going on with the uninsured? And somewhat not surprisingly, expense is the real reason for being uninsured. What you see here is there is a difference here between red states and blue states, where the red states, statistically higher, are saying that it's too expensive. Stephen, what's happening here?
Well, the blue states are all Medicaid expansion states. And so we would expect affordability to play less of a role with the extensive expansions that took place in blue states. And so the difference there is probably a matter of relative priorities within the states, where the blue states have larger subsidies to be able to cover the costs.
We did find that in the red states, just comparing red state to red states, the red states that did expand Medicaid were statistically different on this question than the states that didn't in the red altogether. So again, what's really playing a big part of this, not all of it, but a big part of this, is that the Medicaid expansion, in fact, does make overall healthcare more accessible in a state. Now, we're still dealing here with what's going on with affordability. Affordability has been important to all of us as we look back on what's happened in the Affordable Care Act. We hear time and time again, and we're seeing here, that consumers are saying, you know, it's not affordable. Even if I've got health insurance, what we're seeing here is that half of consumers have to cut down on other expenses to pay for health care. Again, red states worse. Now, we're looking only at the insured. So 2/3 of those who had health insurance are paying 5% or more of their income in out-of-pocket health care expenses. The definition of out-of-pocket is what the person is really paying. Therefore, if an employer is paying some of a premium, that's not included. Out-of-pocket is everything truly that comes out of their pocket in a year. And if you look down here, we've displayed this by percent of income, and so 2% of income, 36% of people are saying that they're paying 2% of income. All the way up to 10% are saying they're spending 20% of income. So this is the people who are insured, 2/3 of them in blue, 5% or more of income. Now, same sort of display, work with me here. We have on the left that same 2, 5, 10, 20%, and we said to them at each level, what is affordable, right? And so at 2% in yellow, 83% are saying that's affordable for me. Okay, these are people with insurance. But interestingly, increasing are finding it not affordable at 20%. This has always really been interesting to me that you're asking 9,000 people completely independently, and yet you see a really almost straight line here. Now then we said to people, okay, you're now insured, you're saying it's not affordable. If it's not affordable, what are you doing about it? Well, and so we said, what are you cutting back on? Well, pretty much across the board, people start taking away their savings, then for all but one, clothing, and then food. So this is not the deal of, why don't I have my color TV? This is people are saying, healthcare is more important to me, and I've got to try to give up something in order to pay for my healthcare. Again, savings, then clothing, then food. Okay, now, same thing, the insured. All right? We looked at and said, all right, what are you spending by income? Okay, so we looked at it by how much percent, right? That's over here. But we looked by what income, right? So if you're at $15,000 of income for your family, the 67% of them are saying that only 2% would be affordable. If we then said, well, how about 5% of income. We get over 80% here, and really, if you look at the top of the blue bars, over 70% at any income are saying that for them, affordable really is 2 to 5% of their income. And for many, many, many of them, they're saying really only 2% is affordable. Now, flip side, for 25 to 50%, right, 25 at the higher level, 50% of the insured people, they're saying their out-of-pocket healthcare expense is not affordable. Remember, the last slide we said, okay, what is affordable? These are people that are saying it's not affordable. And so there's something really interesting going on here, maybe that we wouldn't expect. Stephen, what's happening here?
We would expect to see the highest percentages on the far left, and those percentages to decline steadily as the level of income increased. But what we're seeing here is that it increased in the middle income category between $25,000 and $34,000, and that 50% found it not affordable in that income bracket. And that happens to correspond with about 300% of the federal poverty level, which means that for this income group, they're beyond the subsidies offered in the exchange and typically beyond Medicaid eligibility. So all of the help that government offers with respect to paying their premiums and covering their out-of-pocket no longer applies for that income group.
So we've dealt completely so far with the insured. Now let's look to the uninsured. These are the people who don't have health insurance, and remember, they've told us if they could afford it, they would. But so what's affordable? Well, somewhat surprisingly to a number of us, what the people said was affordable is in green at 2%. So, surely under 15% of $15,000 a year, sure, 68% of people said they could only afford 2%. But how about greater than 75,000? Here are 60% of people saying it. And so this is a really interesting thing to all of us about really the affordability in this group, maybe a little bit different, but pretty much it's the 2% level. Now, why does this matter? Well, we've looked a lot at 2%, but the Affordable Care Act coverage is considered affordable, using the words, if the required contribution for the lowest cost coverage does not exceed 8.2% of income. If it's above that level, the individual penalty doesn't apply, which is basically saying the government says if the premium of the lowest cost silver plan, second lowest silver plan, is 8.2%, you don't have to pay it. You don't get a penalty above that. So this is important as we go forward because it's saying the public's view of affordability is really different from the lawmakers' view of affordability, and we'd better try to reconcile those. All right, switch gears. We asked both consumers and physicians what's going on. Why are we having rising healthcare costs? And the consumers and physicians both said insurance companies, followed by the drug and device manufacturers, and then followed by the federal government. Now, if you look over on the left, we kept the green together, but the green in the drug and device blue and the insurance companies are about the same. There is a real set of differences here. Talk to us, Stephen.
If we look at the bottom and the percentages where consumers appear to find physicians responsible at twice the rate that physicians actually find themselves responsible. And so we have a doubling of percentages there. And likewise, the physicians appear to blame consumers at twice the rate that consumers blame themselves. And so there is some finger pointing going on here, shifting from sort of the faceless insurance companies and device manufacturers and federal government that everyone can blame and point fingers at, to actually physicians and patients blaming each other.
Really interesting. Okay, so we said, all right, folks, you're assessing all kinds of blame. Now, how would we reduce the expense of healthcare? So we said to people, all right, how would you do this? What would you do? Now, interestingly, again, similar order, that what we're seeing is to increase the cost for poor health habits leading. Now, that's not just let's increase insurance rates. This is also let's increase the price of foods that may lead to obesity. So this is both, and we've got other slides that, again, you can look up on the web that says it's not just the insurance, it's also food, it's also sugary drinks. So the top is saying, let's increase the cost for poor health habits, followed by the insurance companies creating an affordable catastrophic plan. Now, that's a lot of syllables there. Catastrophic plan really means to people the bad stuff, except for one, the bad stuff that can happen. Chronic disease, accidents. Now, you don't want to call pregnancy catastrophic, so we might have to call this catastrophic plus pregnancy. What you've heard over and over is that the catastrophic plans so far are too expensive. What the insurance companies need to do, and at least what is being shown by both the consumers and physicians, is saying if the insurance companies could come up with an affordable catastrophic plan, that would be terrific. Stephen, your thoughts?
Again, picking up on the difference between consumers and physicians, they both agree about insurance companies and the affordable catastrophic plan and decreasing insurance payments for expensive drugs and chronic illnesses, consistent with the previous slide. But here, physicians are focusing on consumers' health habits, and they're 12 percentage points higher with respect to finding consumers' health habits a source of potential savings. Consumers, on the other hand, they make up for that, looking towards the bottom of that display, where they believe they want to encourage physicians to follow guidelines, 5 percentage point higher, and then another 6 percentage points higher to decrease coverage for physician services. So we see some of the sources of the difference between physicians and consumers relative to their levels of agreement when it comes to insurance and drug and device manufacturers.
All right. Switched again, but not completely. So what are we after in this pretty much survey of both physicians and consumers? We're after things that may cut costs. That's what we're after. And so I'm going to give you a little bit of background, because there is a method for cutting cost that doesn't necessarily come to mind, but look at, and we will show you that Don Berwick, when he was former CMS administrator, did this marvelous paper in JAMA, in the Journal of the American Medical Association. It should be required reading for everybody. There's the reference up there. And what Dr. Berwick showed is that we waste about $1 trillion per year. That's 1/3 of everything we're paying. And about $192 billion is being spent on overtreatment. Now, he defined overtreatment as the waste that comes from subjecting patients to care that, according to sound science and the patient's own preferences, cannot possibly help them. Okay, so now what's going on with overtreatment? We've now defined it. Well, interestingly, a number of people, and Steve Schroeder, Bill Frist, when he was a senator, came out and said, you know, the way physicians are paid, as in fee-for-service, meaning you do something, you get paid for it, drives up medical expenditures. CMS agreed, and they said, you know what? We're going to develop a new payment methodology, and they did that in 2015, that the U.S. healthcare payments are linked to quality and value instead of the usual fee-for-service. And so we said, we went and looked up whether paying physicians a salary is associated with what? Well, guess what? They do less tests. I'll bet they don't even think about it, but in fact, the statistics show they do less tests. And, is this a good idea, paying physicians a salary? Well, Mayo Clinic, Cleveland Clinic, Kaiser, all of them salary their physicians. So it can't be a really bad thing. We said, hold on, though. What is it that is, that the docs want? So we've got all the nice theory, but we thought, well, let's go look and see how are physicians paid now. Well, it turns out only 1 in 3 physicians are paid 100% salary, and the remainder have a portion paid fee-for-service. Well, now, what's that portion paid fee-for-service? Guess what? It's volume. And so what this says is that the incentives are really dominated by paying for volume, and that's got to shift. Now, we asked them, all right, fine, what do you all think is the ideal compensation? Well, isn't that interesting? 69% of them said that they're interested in being paid salary. 42% said with low incentives. 27% said no incentives at all. Now, that's really interesting to us, that a doable thing could be to increase salarying physicians, and that may really result in lower healthcare costs. Now, you can't do a survey. This is the last slide. You can't do a survey in this time period without at least saying what's going on in Washington. And so we asked physicians and consumers and said, okay, what kind of job do you think the president's doing? Physicians, 10% say a good job. Consumers say 19%. Red states higher statistically than blue, but red states 21%. Ryan, back to you. What have we learned?
Thank you, Dr. Garson. Well, we think there are really 6 key takeaways from our survey. We covered a lot of ground, but here are the points we want you to come away with. First of all, as lawmakers are deciding the future of healthcare in this country, we think it's important that they realize that almost universally, Americans consider having health insurance important to their family. This is a trend we see from blue states to red states to swing states. It's universal across whatever type of state you live in. Number 2, half of respondents said they have to cut down on other expenses to pay for health care. We've all seen the statistics about how little money the average American has in their savings account. This really hits home the point that this really isn't just a health policy issue. It's really an economic policy issue for a lot of people. Number 3, Dr. Garson discussed how the public's view of affordability is really quite different from lawmakers' view of affordability, and our statistics indicating that, especially for the uninsured population, about 2% of income is an affordable amount for them to spend on healthcare, quite different than the 8% the ACA suggests. Number 4, physicians and consumers are alike on a couple points. They both blame primarily the insurance companies and the drug and device manufacturers for the high cost of healthcare and the rising cost of healthcare. That leads to our 5th point. They're also unified in identifying the most likely ways to reduce the cost of healthcare, increasing costs for those with poor health habits, as well as creating an affordable catastrophic plan. And our 6th and final point is that more than 2/3 of physicians want to be paid mostly or entirely by salary. We've seen analyses that indicate that salaried physicians order fewer tests and procedures, and we think this could go a long way towards reducing the $200 billion in overtreatment every year. And the good news is that it seems like the physicians might actually go for this plan. Now we are going to go to the Q&A. So at the top of your screen, you should see a phone number you can call into. We'll let you start making those phone calls, and in the meantime, I'll ask the first question. Dr. Garson, can you elaborate a little bit about what's the link between salaries, doctor salaries, and affordability? Why all these questions about doc pay in a survey about the cost of healthcare?
Well, let's go back to when the Affordable Care Act happened back in the 2008 to 2010, there were two things that really were going on. One is that the cost of health care for everybody was too high even then, and the fact that we had just millions and millions of people without health care coverage. And so what the Affordable Care Act did was have health care coverage for, an additional 20 million people, which is terrific, but it did nothing for cost. And really, I think if you go and you look and you say, look, what are all the things all the way to the Republican bills or the Affordable Care Act, we got to do something to get our arms around really reducing the cost of health care. You hear everybody saying, bend the cost curve. What does that mean? That means, well, the increase, instead of it being 4%, should be 3%. I think it should be less than the cost of baseline inflation, so less than 2% or maybe even negative. What can we do to get cost out? And that's what we're after, and it just turns out that one of the ways to do it pretty simply would be to encourage people that are paying physicians to pay them a salary.
I'll ask one more question as I'm waiting for some of these phone calls to come through, and I'll let either one of you, Dr. Garson or Dr. Linder, take it. If you had the opportunity to present this data to Paul Ryan or Mitch McConnell or President Trump, what's the one data point that you would want to take the opportunity to share with them?
I expect it would be affordability, and we need to reconsider ways to make healthcare coverage more affordable and to boost access as a consequence of making that affordability happen. The out-of-pocket costs we're seeing here are substantially higher than people can afford, and it's really affecting their ability to do the preventive care, to get the tests that they need, and that needs to change if we're going to build health in the general population.
Great. We have a question here that's come in from Michael. Michael says, Dr. Garson, you cite a study that employed physicians order 9 to 33% fewer procedures. Yeah, other studies indicate when private practitioners become employed, their charges to insurance companies increase. He wants to know, what's that disconnect about? Does it have to do with the organizations themselves that are employing those physicians?
So, terrific question. No, we didn't say employed, we said salaried. And there is a big difference between employed and salaried in the physician world, right? So that a hospital or anybody can employ a physician and still they're paid entirely fee-for-service, and they're paid entirely by RVUs. So and this, I think it's important to point out, we see this in a lot of studies where people don't ask, how are you paid? Never mind, how are you employed? So that's, I think, one of the major differences.
Great, thank you. I'll have a question of my own. Dr. Garson, you've been kind of harping on this point about doctor salaries. Tell me how realistic this is. How do you actually implement this on a wider scale so it's not just something that's used by Mayo and Cleveland Clinic and places like that?
Well, great question. I do think that, for starters, the academic centers have been salarying people forever. So there are a number of ways in which, if people want to look for ways to create salary with incentives, there are lots of examples out there. One very practical way to think about this, there is, as part of the government MACRA legislation, one could, and MACRA right now is a very complex method of reimbursing physicians, and it still, in much of what it does, reimburses physicians in a fee-for-service way. I think one potentially simple way to do this, nothing simple in regulations, but to say that if a health plan or a physician group is paying its physicians 50% or more, 75% or more of its physicians by largely salary, that group could get a 5% bonus. So I think that there are actually not simple, but doable ways in which one could nudge plans towards doing that.
Thank you. We've got a phone call coming in from Joanne, who is a bioethicist. Joanne, go ahead. You are live.
Okay, hi. My question is about these policymakers changing the formatting for where it's for them. Why don't they have the same policy that we all do in America?
So,
Like theirs shouldn't be different than ours.
so in terms of the coverage that they have as elected officials, is that what you
Yes.
mean? That we ought to be
Yes.
able to share the coverage that they have? Their,
Absolutely.
Yes, their coverage is a highly selective plan, and it has to do, I think, with the relative health and also the relative income that elected officials tend to average. And it creates a very different risk pool. If I were in the insurance business, I would say that they're at substantially lower risk of using services than the rest of us, because it's a very isolated portion of the demographics of the population. But that aside, in terms of desert, we certainly deserve the kind of coverage that they have. The question is, how do we finance that when our risk pool looks very, very different, and we have people with lots of pre-existing conditions having difficulty getting access and costing the system large amounts of money? We've got to be able to assume that responsibility nationally and have it come out of the tax base.
Again, you can call in with your questions to the number on your screen, or if you want to type a question, you can click the Q&A link on the top left corner. I'll ask one more question. Dr. Garson, Dr. Linder, we got tons of data back from this survey, more than 9,000 participants from across this country. We only went over a portion of that data. In the coming weeks and months, as the Health Policy Institute continues to crunch it, what other questions are you hoping to answer via this data set?
We've got a lot of data on, for example, patients with chronic disease and how they themselves look on obtaining health care and what they think they can do about it. Lots of data on chronic disease. There's some rural versus urban. There are a lot of questions in terms of trying to find out what it is that people want, and then really putting that out to the insurers, the policymakers, to say, listen, you may not know this, but this is really what people are saying that they want and they need. I think there is one, and I hope we can get even further into this, one really important point to come out of the data, out of this morning. You're not going to be able to even address how to do the various approaches to health reform without reducing cost. That's just there, all right? And if you go back and you look at the Affordable Care Act, Obamacare, and you look at any of the proposals since then, none of them are really addressing the root problem that healthcare is too expensive. And so this notion that we were just getting at, and there's a fair amount of data beneath it, of what consumers say they think that they can do, and physicians think they can do, is really important, because this is a little bit of moving the deck chairs. We've got to figure out how to reduce the cost of healthcare, and that's our problem, all of ours.
Well,
This is the third annual survey that the Health Policy Institute has conducted. And what's different in this survey is that we've taken a careful look at the differences between the blue states and red states and added in the swing states in order to better understand what the partisan dynamics are. And there's, in the data themselves, a lot of ways to explore the partisanship issue and the contrast between blue and red states. And I'd recommend that as a subsequent focus for inquiry with these data.
Okay, we've got a pretty interesting question coming in. This person writes, unfortunately, the lower scale of income typically have the worst health benefits. Charging them more for their health habits will actually make healthcare less accessible. A suggestion would be, rather than increasing their costs, give incentives to good habits such as costs for gym memberships, healthy food, etc. Does that idea have merit? Maybe discuss the sort of the advantages and disadvantages of that approach rather than charging more for bad health habits.
So I thoroughly agree. Okay, just to make sure that I say that at the front, that all of these ways of increasing cost hit the lower income worst. I got it. And so you could imagine that even some of these different ways of dealing with charging more, not going to the fast food place and saying, what's your income? But maybe some of the employer-related could actually relate to their income rather than just saying across the board. So I think, first of all, you're correct. I think these things do hit the lower income unfairly. I agree. Unfortunately, the data are not really out there on the gym membership sort of thing because, and again, I think gym membership is terrific. I'm just talking about the data. That after 6 to 12 months, and I'm being a little bit hyperbolic, but what you find is that the people who are still going to the gym are the people who are going to the gym in advance. Now, obviously, in the individual case, that's not true. But the point being, some of these wellness initiatives really need to sort of find out the best ways. I think the wellness initiatives are terrific, but we got to find out ways in which we can help with behavior because some of them aren't working as well as we think they could.
The idea of a fat tax comes out of some field work that was done that proved as you increase the cost of sugary beverages, the consumption went down across the entire population. The consumption wasn't necessarily concentrated in the lower income levels. But the related finding when it comes to population health is that there is no magic bullet for reducing consumption of sugar or changing people's health habits so that they can prevent chronic disease or lessen its consequences for their health. A wide variety of interventions are necessary. So what you need is really a bundle of things that you can put in place, some involving incentives, positive incentives, some involving some negative incentives to change people's trade-offs when it comes to the selection of things to consume. And others have to do with changing attitudes and more generally the whole culture of health in populations. And we haven't been able to get at that in the questions we asked here since they were consumer-oriented kinds of questions. But we ought to be considering that in the future.
Just one piece of data that's important to sort of focus on a little is that the World Health Organization will tell us that the major thing that got people smoking less around the world was the cigarette tax. So this is not just sort of based on, gee, shouldn't we do something? Now, there's lots, as Dr. Linder's saying, there's lots of different things that go into behavior, but unfortunately, monetary is certainly one of them.
We've got lots of good questions. We're going to try to get to as many as we can. Jawoon Kim asks, we've talked about financing the high cost of healthcare, but what are your thoughts as to the root cause of why the bill is so high in the first place? Why should a hospital stay cost as much as it does? Do you see that variable decreasing in the future? So we've talked about this big number, the estimated $1 trillion annually in waste in the healthcare system. We've talked about $200 billion in overtreatment estimated annually. Where's the rest of that coming from?
Well, again, I would really suggest that you look at Don Berwick's article. It is wonderful. The next, it's actually not the next lowest, it's actually higher. Of the one that is 250 billion is administrative waste. Now that doesn't help anybody except the people who are spending the administrative waste. take, for example, walking into the clinic and having the people ask you 3 different times in 3 different places in the same clinic whether your health insurance has changed in the last 36 seconds. It's those kinds of things that employing people really are wasteful. You look at the U.S. versus Canada, and I'm really not necessarily talking about single payer or not. That's not the issue. The issue is, however, that Canada's administrative expense is 50% of the U.S. administrative expense. And if you just stick with the U.S., Medicare has 2 to 3% administrative expense compared to like 16 for the private insurers. Again, this is not saying anything about the private insurers. This is to say that the efficiencies that are there could be had with better information systems, with better ways in which an insurer can have what they need, but that it's almost seamless in terms of what approval processes are needed. This is $250 billion a year. Just to put that in perspective, what does that mean? The entire current subsidy for the Affordable Care Act is $110 billion per year. So if we cut administrative waste in half, you could pay for all that's going on right now with with what's being sort of the money being given out in the Affordable Care Act to help people pay for health insurance.
Great. We've got another question. This person says, I think the results from the physician and consumers were interesting on who they blame for healthcare costs. I'd be interested in knowing, did you question the insurance companies? And the answer to that is no, but maybe I'll reframe the question. You both know people who work in the insurance industry. What would their reaction to these findings be from consumers and physicians?
Well, the insurance company people we've spoken to about these findings are baffled by what it is they're made to be the goat, because they don't believe they're contributing to the spiraling costs, that in fact they believe they have lots of measures in place to keep the costs down, and they're almost exclusively, from their perception, a victim of the way the system is organized, and they're doing their best to survive within that context. So you see, if we had included insurers' points of view, we would have had a three-way kind of conflict in what the perceptions are. The compelling thing in these data is that kind of finger pointing and shifting of responsibility doesn't really apply across party lines. That is to say, what we'd expect going into this is that it's a partisan issue and the red states will blame the blue states and vice versa, or that people in those 2 designated states, their party affiliation is going to affect their view of the world.
Well, on that note, we will conclude this webinar. Our slides and our data will be available on our website, tmc.edu/health-policy. Thank you for joining us.